Hello, everyone, and welcome to the Relapsed Refractory Myeloma Patients chapter launch as a part of the Myeloma Crowd Community Program by HealthTree. My name is Audrey Burton-Bethke, and I am the Myeloma Crowd Community Manager. We are thankful for each of you taking the time on a Friday evening to be with us as we discuss the newly FDA-approved drug Melflufen with you today. This meeting will be moderated by Jenny Ahlstrom, who is the founder of HealthTree and the Myeloma Crowd. The presentation will be by multiple myeloma specialist Dr. Agne from Rush University, whom Jenny will formally introduce in just a few moments. This meeting will be recorded and sent out to all registrants. Jenny, the time is now yours.
Thanks, Audrey. Welcome, everybody. And I'd like to start by thanking our sponsors, without whom this event would not be possible. Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. Now, as Audrey mentioned, today's topic for the launch of this relapsed refractory myeloma patient group and chapter will be a new drug for relapsed refractory myeloma patients called Melflufen. Melflufen, or now the commercial name PEPAXTO, was recently FDA approved for relapsed and refractory multiple myeloma patients who have received at least 4 prior lines of therapy. Dr. Agne from Rush University will explain to us today what the new therapy is, who qualifies for it, when it should be considered, and how it works. We'll have a question and answer session at the end of her presentation. So if you have questions during the presentation, take a look at the bottom of the screen where you can find the Q&A and enter your question at any time. Now it's my pleasure to introduce our featured speaker. Dr. Panner is an associate professor of medicine in the multiple myeloma and amyloidosis program at Rush Medical College. Her research interests include clinical trials with innovative approaches to the treatment of patients with myeloma and amyloidosis. She had hands-on experience in the Horizon trial, which is this trial, and was the very first doctor to treat patients with PEPAXTO in the United States. So we're excited about that. And she has been treating myeloma for over 10 years. And Dr. Panner, I'll turn the time over to you.
Well, thank you kindly for the introduction and for invitation to introduce the new kid on the block, the Melflufen. I'm very excited to share with you the information about this new treatment option for multiple myeloma. I'm just going to take a second here to set up my slides, and can you see them all right?
Yes, we can.
Okay, wonderful. So let's get started then. So the new drug is Melflufen, and it's also called Melfluffin flufenamide. You can find literature with both names. It originally started out as Melflufen, and only in the past year was changed to Melflufen flufenamide. So if you see two different names, don't get confused. We are talking about the same drug. And I would like to explain a little bit, where does Melflufen flufenamide fits in? So this drug belongs to alkylator drug group. I created this table here to show you the major classes of the drugs that are used for treatment of multiple myeloma. So in the very first column on the left, we see alkylators. That's by far the oldest drugs ever approved for multiple myeloma. Melflufen is the grandfather of all. It dates back to 1960s, and it's still used actually for conditioning regimens for autologous stem cell transplant today. So not to get confused, Melflufen and Melflufen flufenamide are two different medications, and soon it will be clear once I explain the mechanism of the action of the new drug. There are some other alkylators like cyclophosphamide, bendamustine that also belong to the alkylator class. They have a similar mechanism of action, but also certain nuance differences. And the next large group is immunomodulatory drugs, then proteasome inhibitors, and then anti-CD38 monoclonal antibodies. So I would say those are three major classes of the drugs that we use for treatment in this century. From immunomodulatory drugs, you probably know well lenalidomide, which is also known as Revlimid, pomalidomide, which is also known as Pomalyst. From proteasome inhibitors, bortezomib is commonly used in upfront treatment. It's also known as Velcade. Ixazomib, which is a little bit like oral form of bortezomib and called also Ninlaro, and carfilzomib, which is also known as Kyprolis. And in anti-CD38 monoclonal antibody group, we have two antibodies now. So daratumumab was first to be approved for treatment of myeloma, and that is also known as Darzalex. And now we also have another monoclonal antibody that was approved just within the last year. It's called isatuximab, also known as Arclisa. So these three classes of drugs are so important that patients who receive standard of care treatment for multiple myeloma should really be exposed to at least one drug in this class of drugs: IMiDs, proteasome inhibitors, and monoclonal antibodies. They all are FDA approved, and when patients become refractory to these three classes of drugs, we call them triple class refractory. If they are refractory to both IMiDs, lenalidomide, pomalidomide, to both PIs, which is bortezomib and carfilzomib, and to daratumumab, then they are also considered pentarefractory. So it's terminology that I like to explain in detail because it will also help us understand when we talk about the clinical trial why Melflufen was approved the way it was approved. So our unmet medical need is everything outside of the box of these three major classes of the drugs, all right? And the new agents can be better drugs or innovative drugs within the same class of the drugs. So today specifically it pertains to alkylators. We'll be talking about Melflufen. There are also novel agents that are being developed for triple class refractory patients like iberdomide and IMiDs. Isatuximab was already approved last year. And drugs can have entirely novel mechanism of action. So last year, belantamab was approved for treatment of multiple myeloma, which is anti-BCMA monoclonal antibody drug conjugate. And just recently we had CAR T-cell first in history approved for treatment of multiple myeloma. Celinexare is the only drug known in XPO1 inhibitor class. So they attack myeloma cells entirely differently than IMiDs, proteasome inhibitors, or anti-CD38 monoclonal antibodies. And I did want to highlight Melflufen here because it does have a very unique mechanism of action, even though it belongs to alkylator group. A little bit more of terminology that we see in clinical trials. I'm sure a lot of you have attended a lot of meetings on multiple myeloma therapies and may be familiar with these terminologies, but I expect that maybe also some patients who are new to this. So it's worthwhile to spend a few minutes just to make sure we know the language that we're using in this presentation and clinical trial analysis. So what is the phase of the trial? Usually when we say this was approved based on clinical trial, we want to mention what kind of phase it was. So there are three major phases of drug development. Phase one is usually a very small group of patients that have no treatment of options, and this is the first time the drug is ever used in humans after being tested in lab and with animal models. And in phase one trials, we determine if the drug is safe, and we try to determine what dose balances out the effectiveness and the toxicity. And once we figure out that dose, then we can expand it to a larger group of people, but still usually less than 100 patients, and that would be phase two trial. The goal of phase two trial is to determine how active is drug and still follow up on the safety, because now it's applied in a larger group of patients. So what is the effectiveness is usually determined by response rate. Response rate is usually the key finding in the phase two trials. And then phase three trials are usually the largest ones. They many times are randomized, where patients are compared in standard of care arm to experimental arm. And that experimental arm is many times going to be a new drug added to old regimen or replacing some other drug in the old regimen. So today we will be focusing on phase 2 trial. That's what led to Melflufen approval by FDA. It's important to pay attention to patient population. So we'll be talking here about treatment for relapsed refractory patients with 4 prior lines of therapy and refractory to at least one drug in those 3 major categories of the drugs. So this would not apply to patients with newly diagnosed multiple myeloma. This drug would not apply to patients who are relapsed for the first time. So when you read this information on new drugs, it's very important to understand in which context that drug was developed and where it fits in your story, or maybe it doesn't fit in. Primary endpoint. So when we talk about clinical trials, there's a lot to mention. There's a lot that we can learn from the studies. But the primary endpoint is going to be the goal of the study, what the study is set to prove, and that proof is scientifically sound. So we can learn a lot of things that are hypothesis generating, that are intriguing, but they don't have enough of statistical power to say this is what the study proves. And in phase 2 trials, primary endpoint is usually overall response rate. So overall response rate, it's usually how many patients had at least partial response or better, meaning how many patients shrunk the tumor or monoclonal protein by half or more. And typically when in a phase 2 trial, you see at least 20% response rate, meaning 1 out of 5 patients shrunk the tumor or the disease by half or more. It's considered very promising drug. So that's a kind of good reference number to keep in mind. In the phase 2 trials, if the drug was more than 20% effective, it's worth investing in developing this drug further. It may not sound like a lot, 1 out of 5, but remember it's usually applied for patients who have no treatment options. And typically when you develop drug into earlier lines of therapy, therapies are more effective, right? The more refractory disease, the harder it gets to treat it. Progression-free survival is how long patients remain in remission on average. So that includes patients who responded and also patients who did not respond to the treatment. It's an average number. Overall survival is how long patients lived after starting the treatment. And that's what is considered a golden standard in clinical trials. If you can prove that the therapy improves overall survival, that's the most important thing you can do with a treatment. Of course, you still want to think about at what cost, what are the side effects, quality of life. But still, if you can prove that something improves overall survival in patients, that's a valuable therapy. And then adverse events. Again, any success in medicine, any effective drug has to be weighed in against the side effects, right? It could be a very effective drug, but if you can't tolerate, if it totally ruins your life or your body, then it doesn't matter how effective it is. So balance between effectiveness and risks of therapies. And now let's dig into data on Horizon clinical trial. These slides were shared with me by Oncopeptides, the pharmaceutical company that sponsored the clinical trial and that developed melflufen. I had a pleasure to be a principal investigator in my institution at Rush University Medical Center in Chicago. We enrolled quite a few patients, and as Jenny mentioned, I had a pleasure to treat the first patient on this trial in the United States. So it will be nice to share with you what were the results and also maybe my personal experience with this drug. So Melflufen or melflufen is now approved in combination with dexamethasone for treatment of patients with relapsed refractory multiple myeloma who had at least 4 prior lines of therapy, meaning they had relapsed at least 3 times. Because first line therapy typically will include induction, transplant, and maintenance. Even that sounds like it's 3 different treatments, it's 1 line of therapy, right? So the treatment till progression of the disease is 1 line. And patients should be refractory to at least 1 proteasome inhibitor, immunomodulatory drug, or anti-CD38 monoclonal antibody. In other words, triple class refractory. And again, it's very important not to get confused that this is not the same Melflufen like was developed in 1960s, and this drug should not be used for conditioning regimen for transplant. So how does Melflufen work and how different it is from Melflufen? This is a very interesting drug. It's actually a peptide conjugated drug. So there is an alkylator piece to it, and then there is a peptide piece. And in this picture, it's pictured as this green and blue kind of figurine. So the blue part is the alkylator part, the drug that treats, and the green part is the peptide carrier. It's the part of the molecule that helps drug penetrate into plasma cell. And when the Melflufen is combined with peptide carrier, it becomes very lipid soluble, so it very easily penetrates into the cell. Now, multiple myeloma cells are like little protein factories, right? All they do is produce monoclonal protein. So by that, they are also very rich in enzymes called aminopeptidases, enzymes that cleave and destroy those proteins. So once Melflufen gets into plasma cell, aminopeptidases are able to cleave and get rid of the peptide, and then they release the alkylating agent who can go into nucleus and do its job and destroy the genetic information of the cancer cell. So once it's cleaved, it becomes hydrophilic, meaning it dissolves well in water but not in lipids, and therefore it cannot leave the cell. It gets trapped inside of the cancer cell. It also creates a concentration gradient, right? It kind of helps to pull in even more of Melflufen or melphalan flufenamide, because now inside it's been broken down and the nature likes balance, so it pulls in more of a drug into the cancer cell. For this very reason that multiple myeloma cells are rich in aminopeptidases and other cells are not, the drug is very targeted. You will see that once we talk about side effects, there's very little of side effects that typically we will see with alkylating agents, because this mode of delivery allows more alkylator to be present where it should be in the cancer cell, and less of the alkylator to be present where we don't want it, and that's in the bloodstream and other organs. So that's how Melflufen works. This is a very busy slide. I hope we spend enough of time, and if you still have some questions, so perhaps we'll clarify it in Q&A section. But you can imagine that this mechanism of action really allows very high concentrations of the drug within cancer cell. And in studies, it's been shown to be even up to 50 times higher concentration in the cancer cell than in the blood with regular Melflufen. Now, who were the patients who participated in the phase 2 trial called Horizon trial? There were 157 patients. They were older than 18, and they had to be refractory to either pomalidomide or daratumumab or both. And they had to have at least 2 prior lines of therapy that included IMiD or proteasome inhibitor. They were treated with melphalan flufenamide in combination with dexamethasone. Melphalan flufenamide is given as intravenous infusion over 30 minutes, and it's given every 4 weeks. And as it is now, it has to be given through central line, either portacath or PICC line. And now the primary endpoint, the goal that the study had to prove was response rate, overall response rate. There were secondary endpoints as well, things that we want to know about, for example, like duration of response, progression-free, and even quality of life. So this was a design of the study, and patients continued treatment as long as they were responding to it or as long as they were tolerating it. Now, if we break down even more, actually what patients in the study were like, we can see that majority were around 65 years old, which is an average age for multiple myeloma. There were rather representative distribution of gender, the stage. And what's important to note here that these were very sick patients. More than a third of them had so-called high-risk cytogenetics. That usually tells us the disease is acting aggressively. More than a third of patients in the study had extramedullary disease. So multiple myeloma is supposed to stay inside of the bones, but when it starts to grow tumors outside of the bones, we call them extramedullary plasmacytomas, and that too usually speaks to aggressive behavior of the disease. So we tend to see that more so in the relapse setting than in newly diagnosed patients. And then more than 2/3 of patients in the study were triple class refractory. More than half of them had been treated prior to this with different alkylator and were refractory to it. That's also an important point to make. So what was the response rate? What was that primary endpoint? The overall response rate was 29%. So it does get it above 20% of cutoff and shows us that this drug is indeed very active. If actually we look at the historic data of commonly used drugs now, like daratumumab, carfilzomib, pomalidomide, they too had a response rate in a similar range between 20 and 30%. So this is a very promising response rate. Now, clinical benefit rate, abbreviated as CBR, is 45%. And that includes not only patients who responded and had their tumor shrink in half, but also patients who maybe had only 1/3 of shrinkage of their tumor or stable disease, which can be of value when you have a relapse refractory disease. So nearly half of patients had at least stabilization of their disease. And if we look at triple class refractory patients, which was 119 patients total in the study, their response rate was also very similar, 26%. Now, duration of response. So among patients who responded to the treatment, their response lasted about 5.5 months. Among patients with triple class refractory, and that's 31 patients, response lasted 4.4 months. Now, this graph actually is a little bit complicated to read, but it does give some very good visual information. So those lines represent patient going through the treatments, and the lights, the colors, represent the depth of the response. So the lightest grade is where the stable diseases are, meaning there is no response yet. Then as it turns greener and darker, the response gets deeper. So you can see how most of patients will respond to treatment within that first 2 months of therapy. So it's a pretty quick response. And I will share my personal experience that, I could tell that patients are responding in the first couple of weeks. The impact on where the well-being was visible before we could measure it by the blood test. So most patients respond early and they deepen the response with additional therapy. And what's also interesting that some patients continue to deepen that response even after therapy is completed already. Maybe they had to stop it because of the side effects or some other reasons. You can still see that response can linger. Now, secondary endpoints. So we talked a little bit about duration of response. Now, progression-free survival, that includes not only patients that responded, but also patients who didn't respond. And that's about 4.2 months for all the patients, 3.9 for triple class refractory. Patients who had at least partial response, their progression-free survival was 8.5 months. Now, as entire group, patients had overall survival of nearly a year, 11.6 months. But patients who had at least partial response, their overall survival, how long they lived after starting this therapy, was practically a year and a half. So that's a good kind of reference to keep in mind what you can expect with this treatment. There is about 1/3 of chance of responding to it. And if you respond, you can expect to stay in remission for actually half a year or even longer. Now, when it comes to side effects, what's important to note that oops, that's a bit of an unexpected. Let me see if I can fix it. Okay, there we are back. So the side effects, the major side effect is that on the blood counts. So it is a myelosuppressive therapy that's common for alkylators. That's a well-known side effect, and that's no different with Melflufen. So the most common side effect were low platelets and low white cell count. And in over half of the patients, they were actually pretty severe. Now, what we don't see is severe other side effects. So when it comes, for example, to nausea and fatigue or diarrhea or constipation, common side effects that affect quality of life, those are not common, and especially uncommon to have severe ones. So other than low blood counts, this drug is actually well tolerated, which is also important, especially when you have a patient who's already been through a lot of therapy and can have a lot of symptoms from the disease itself. Now, when I mention low platelets and low white cell counts, it's also very important to put in a context of how clinically meaningful are those numbers. So if your platelets are low, you could be at risk of bleeding. And if your white cell count is low or your neutrophils are low, you could be at risk of infection. So we will look at the rate of bleeding in the study, that among patients who had thrombocytopenia, or apologies, this is actually among all the patients. If we take all the patients, 157 patients on the clinical trial, about 16% of them had some form of bleeding, and less than 3% had severe bleeding. So when we say grade 3 or 4, those are severe side effects. Those are side effects that either affect your quality of life or land you in a hospital. When we say grade 1 and 2, we refer to mild side effects. And when we look at infection rate, overall in the clinical trial, there was about 30% of patients getting infection of some sort, and about 10 or 11% of those getting severe infection. And that actually is pretty comparable to a lot of therapies for myeloma. Rate of infections in general is increased in patients with myeloma. And if you look at multiple different studies, the rates of pneumonia typically are somewhere in the range of 10%. So that also helps to kind of make a meaning of thrombocytopenia or neutropenia in the range of 60 to 70% of events. That not all of them actually have impact in terms of bleeding or infection. It's a fraction of them that get patients into trouble. To summarize, melphalan is approved for treatment with dexamethasone for patients that are triple class refractory and had progressed through four lines of therapy. In patients with, it's effective even in patients with very aggressive disease, such as triple class refractory or extramedullary disease. So response rates in the trial that led to FDA approval was 29%, and clinical benefit rate was 45%. Median duration of response was 5.5 months. Progression-free survival was 4.2, and overall survival was 11.6 months. When it comes to safety of melflufen in combination with dexamethasone, majority of patients did have some form of side effects, and most of the time it was either low white cell count or low platelets. And among the patients on the study, it was a minority that had a severe bleeding event or a severe infection. So severe bleeding happened in about 3% of patients, and severe infections happened in about 11% of patients. And then there were very little of side effects in terms of fatigue, nausea, vomiting, or diarrhea or constipation. So this is promising treatment. It compares well to other options available for triple class refractory multiple myeloma. And I think with that, I will open us for a discussion for questions and answers.
Okay, great. And you can unshare your screen if you want to.
Mm-hmm.
Perfect. I thank you so much. I love how you went through some of the basics too, because sometimes I feel like we go through things a little bit too quickly, and it's a really nice refresher to understand some of those things, just like progression-free survival and overall survival, so you get the context. I'm going to invite everyone to ask their questions, and there are some questions already in the chat, so I think we'll go through some of those. So with melphalan, I know there could be a risk of secondary cancer. Steve is wondering if that's been seen in the melflufen.
Right. So this is a very, very good question. Alkylators as a class can increase the risk of other blood cancers like myelodysplastic syndrome and leukemia. And we're well aware of that risk after autologous stem cell transplant. Now, melflufen has been studied in patients with relapsed refractory disease, and overall survival in these patients was about 1 year. When you develop secondary malignancy from alkylators, it usually takes longer than a year to see that. So I think it's just not the setting where we can clearly get the answer to the question. As melflufen progresses into earlier lines of therapy, and perhaps if we eventually use it for conditioning or for a transplant, then we'll be able to get a better idea, does it actually increase risk of other malignancies? I think in the studies, maybe 2 patients were reported to develop secondary primary blood cancer while in treatment with melflufen. But then again, they were heavily pretreated. They had 2 prior transplants. So it's hard to attribute it to melflufen.
Right. And they could have been on Revlimid for many years, and that's a known cause also. Yeah. So you just don't know. But
it's a good question, and I think eventually we will know.
Yeah, well, you'll have to bring it up earlier, right, in different lines of therapy.
Right.
And I think that's interesting that it's better for extramedullary myeloma patients. I think that's an interesting point you made.
Yeah, it's not entirely surprising, I would say. Extramedullary plasmacytoma, sometimes we refer to as a lymphoma-like behavior in myeloma. And it's been noted even before that classic chemotherapy that is effective for lymphoma can also be effective for that kind of presenting myeloma. Yeah, so it's not entirely counterintuitive, but it is a very tough disease to treat. So it's good to have treatment options for patients with extramedullary disease.
Right, and that's why it's exciting to have this new drug in the arsenal, because it's yet again another option for us. Okay, Michael has a question, and I'm going to ask it in a broader way. So he wants you to compare it to Celinexare, but I would like you to do it a little more broadly in addition to answering that question, because what we're hearing from relapsed refractory patients is this is a good problem to have, like we were talking about earlier, to have all these different options. But how do you know when to use what? I mean, it's such an art and a science. How do you do that?
Right. So again, it's a good problem to have, and how we make those decisions is, taking into account multiple things. First, what therapy is most likely to work, right? And then among those therapies is which one patient is going to tolerate the best. So you want to think of the best chance to respond and stay in remission, and then about, what way you can get there. What quality of life or what risks are you going to take to get to that result. So we pick therapies thinking about what the comorbidities patients have, what side effects we can expect to treatment, and try to match that.
Mm-hmm.
So good things to know about Melflufen as well as Celinexare is, for example, both of those drugs do not give peripheral neuropathy, which could be an issue for a lot of patients. Common side effects for all the therapies in triple class refractory space will be low blood counts. Typically myeloma, even though it's a blood cancer, it doesn't quite affect blood counts as much. One of the classic symptoms is anemia, but other than anemia, we don't see low white cell count or low platelets like we do in leukemia or lymphoma, myelodysplastic syndrome. But by the time patients have been through multiple lines of therapy, they usually have low blood counts to begin with. And partly for that reason, these therapies can further worsen blood counts. It becomes easier to notice that blood counts are dropping. Now, major differences between Melflufen and Celinexare is that side effect profile. Other than low blood counts, with Celinexare, there's quite a bit of nausea, fatigue. It's a pill that you take, but with that pill, you have to take a lot of supportive medications, and you may have to make some trips to infusion center to be checked on, to maybe get hydration or transfusions. Melflufen is intravenous therapy, so you have to come for it to infusion center every 4 weeks, and you may still have to come in between if your blood counts are low to be checked on and possibly get transfusions. But we don't see a lot of nausea. We don't see a lot of fatigue with this therapy.
Mm-hmm. Okay, that's great to know. Another question is, can you talk about that these drugs are approved as single agents, right? Used by themselves, and that's where you're getting the percentage that you talked about of response.
Yeah.
But they're never really applied that way in the normal myeloma clinic, right? By themselves, because there's more synergy having these things together. So can you talk about the treatment combinations that for their approval? And then I know some doctors will use these drugs in an off-label sort of way. Can you talk about that a little bit?
Yeah, so typically drug will be approved as a single agent first, because that's how we get an idea, does it even work, right? And then once it does work, then you are ready to combine it with what's already available. There are 2 studies right now ongoing of Melflufen combination with daratumumab and Melflufen combination with bortezomib. But the data is very early, so it's hard to tell yet what you can expect with that treatment. Response rates are always better if you combine more drugs, and that's the reason why we try to do that in multiple myeloma. But then you also have to weigh in, are there increase in side effects with combinations?
This was approved with Dex, right? Or correct me if I'm wrong.
Correct.
Okay.
Yes. Dexamethasone is given on a weekly basis with this treatment.
Okay, great. Okay, good to know. And good to know things are coming up. I know as soon as something gets approved, then you start combining with other things or running simultaneous trials or start moving it up a little bit, before the 4 prior lines of therapy. So that'll be exciting. Jack has a question, and he says, I've seen a number of myeloma experts say I'm not planning to use melflufen until it can be shown to work better than melphalan or Cytoxan, but maybe that's not applicable because you might have already used melphalan. At some point, okay, how do you reply to that type of statement?
So in the clinical trials, 60% of patients were treated with prior alkylators and were refractory to those alkylators. So that tells you if those patients can still respond to melflufen, that melflufen is more potent, right? And even if you already have been on melphalan and Cytoxan and it didn't work, there is a chance you will respond to melflufen. Or you could straight go to melflufen if you want to use the drug that's more likely to give a response. With melphalan alone, seldom do we use it anymore. Most patients at the best will get partial responses. I personally can count on my one hand how many patients I have treated with oral melphalan, and I've been treating myeloma around a decade now. So it's really an old drug that we seldom use.
And you mentioned that it's not used for transplant. So I think, the distinction you're making is melphalan is used if you're headed to transplant. It's this, lymphodepleting
Mhm.
therapy that brings you all the way down and you come back up when you get your stem cells back. But melflufen is not being used in that way at all. Do you ever see it being used in that way in the future as
Yes,
part
I
of
think
transplant?
we all are asking that question. What if it's that good in relapse refractory, what could it do in transplant? And then you don't have to worry about low platelets and white cell counts because you're going to fix that with stem cells.
Mm-hmm.
So I believe those trials are going to get started. There might be some tweaks to melflufen, but that's probably the future where we're going to see it.
Well, less toxicity during the transplant process would be ideal
Yes.
for everyone. Okay, I think you answered this question already. Someone asked, I have smoldering myeloma. Is this something I can take to prevent full myeloma? And this is for patients who have had who full myeloma and have prior lines of therapy, 4 prior lines of therapy. But are there other instances where you see additional trials being opened? So you talked about transplant trials, you talked about DARA and Velcade. Are there other places this drug is headed? I guess this is my question.
Yeah, actually, it's going to be studied also in amyloidosis, which is related to multiple myeloma. It's different disease, but it also comes from plasma cell, and it usually has less options, harder to treat than myeloma. So that's exciting for myeloma community, even may not directly apply to patients who have pure myeloma without amyloidosis.
Mm-hmm. That's great. Well, amyloidosis patients need a lot of new therapies, so that's really exciting. Thomas is asking, how does the progression-free survival and the overall survival compare with melphalan?
So these to have a really good answer, to have honest, scientifically sound answer, you have to do a clinical trial where you give half of the patients melphalan and then half of the patients melflufen. And those patients should be rather similar in both groups. And it should be computer that decides who gets who so that there is no selection bias. And then see how those patients respond and how long they stay in remission and how long they live. So that trial will never be done. We can only look at the historic data. But see, melphalan as a single agent was studied before we had Revlimid, before we had bortezomib, and melflufen is studied in a very different patient population. So we will never have a clear answer to that. But I think the mechanism of the action and the fact that patients who are refractory to alkylators, 2/3 of them in a clinical trial respond to this drug.
Right.
You could, I think, simply put say melflufen is stronger than melphalan. That's as close as we can get to the answer.
Yeah, because the others didn't work. Or you
Mm-hmm,
relapsed
mm-hmm.
after. Anne Marie is just asking you to go into an explanation, a little bit of something you mentioned earlier, why extramedullary disease can have lymphoma type of behavior. What is it about that?
Well, so when we say lymphoma, we mean that it forms tumors, masses. Multiple myeloma usually stays within bone space, the bone marrow space. And when it starts to form tumors, then on scans, sometimes it can be mistaken for lymphoma. So it's mostly that. And then the biology is a little bit different. It can be rapidly proliferative. Usually those extramedullary plasmacytomas grow fast. And they can cause a lot of trouble in the surrounding structures. If you have a tumor pressing on your heart in a windpipe or on a food pipe, you're going to notice you'll have difficulty breathing,
Right.
swallowing. So shrinking those tumors is really important.
Okay, great. MJ is asking, can it be used in plasma cell leukemia? So, yeah, that's interesting, right?
Yeah, that's a very good question. I see why not. It probably wouldn't be an upfront treatment choice. I would go with something that's more proven, has more historic record in plasma cell leukemia. as you know, there's really very, very few studies that specifically looked at how to treat plasma cell leukemia because it's such a rare subset of multiple myeloma. But certainly if you have a patient who's relapsed, I think melflufen would be reasonable to try in a patient with plasma cell leukemia.
We have another question too, that how do you access this drug, or how is it widely available now? So are you hearing it being used?
Well, it just got approved.
Right.
It just got approved. So
Yeah.
really a few weeks ago. So it's gonna take some of the time to get to the shelves and for doctors to get access to the drug.
Okay. Somebody wants just kind of a description or an explanation. He's asking, what's the difference between myeloma and extramedullary plasmacytomas? Can you have the extramedullary plasmacytomas without having myeloma
Okay, so the key difference is between solitary plasmacytoma and multiple myeloma. If you have only one tumor that's made of plasma cells and no plasma cells anywhere else, no other tumor, no plasma cells in the bone marrow biopsy, that's called solitary plasmacytoma, and it can be growing either from the bone or entirely in a bone unrelated area. And that type of situation is unique. It's potentially curable. 50% of these patients, roughly speaking, could be cured with radiation therapy alone. So they are treated very differently than multiple myeloma. And multiple myeloma actually did get its name from being tumors in multiple places.
Right.
If you've ever seen that very old historic picture of young woman with almost every bone in her body broken, so once you have two, that's multiple. So if you have two tumors, two plasmacytomas, that's already multiple myeloma. So I hope that explains it.
Yeah, great explanation. Okay, Peg is asking, she's had myeloma for 13 years, triple class refractory. Her doctor's considering Blenrep. What class of drug is that, and how does it compare? These are the types of questions that patients we're getting all the time. Like,
right.
Hey, now that I'm through those three, what do I do, and how do I decide?
Yeah. So you have at least three options now, four actually, because CAR T cells just got approved last week actually. So Blenrep is belantamab mafodotin. It's a monoclonal antibody drug conjugate. So it's also a combined molecule where there is a monoclonal antibody, but there's also a drug attached to it. And it targets BCMA, which is B cell maturation antigen that is very specific to plasma cells. So even though I didn't prepare slides for it, but it was approved based on DREAM2 study, and the response rate was also in a range of 30%. So very similar to what we see here with Melflufen. Now, the major difference is in side effect profile. It's also a drug that's given intravenously. It's given every 3 weeks. Low platelets, low blood counts could be a problem. But most importantly, it's the eye side effect. Patients can develop dry eyes or blurry vision. Medically, that term is called keratopathy, meaning that the lining of the eye can develop these cystic changes. So you have to work not only with your hematologist, but with also eye specialists, so with an ophthalmologist, to check your eyes every 3 weeks. And then if you do develop those side effects, the drug can be held and then reinstituted once eyes get better. And they almost always get better. Nobody has gone blind from this drug.
And you can, and it's temporary if you are off, right? So Tan is asking a question: is there data that shows any significant difference by race in the response of patients, particularly African Americans, for this particular drug? And if so, do we know why?
Well, that's a very, very good question. We don't have enough of those studies, I have to say. I think partly, and it's very sad because way more patients who have myeloma are African Americans, but way more patients who participate in clinical trials are not African Americans. So it is hard to draw those conclusions. I think one few interesting like historic data is that, it seems like patients with African American race have greater prevalence of hyperdiploidy compared to translocations, and that makes them perhaps benefit from Revlimid, from immunomodulatory drugs more. There have also been studies looking at translocation 1114, that perhaps could be more common in African Americans, and then the drug that is not FDA approved, and I don't know if it ever will, but it is specific to that translocation 1114, is called venetoclax. But it's not a hard data. It's I'd say for the best part, it would be hypothesis that these drugs should be prioritized.
Can I ask a question too about clinical trials? Because normally you talked a little bit about this in the beginning, that you have these phase 1, phase 2, phase 3, usually approval after phase 3. But this one was approved after phase 2 with 157 patients. So are you seeing that more now in myeloma? I think daratumumab was almost kind of like that, right?
Right. So
Yeah.
it happens when you have patients with unmet medical need. So if you have, and all these trials kind of ran at a similar time, the belantamab, Celinexare, Melflufen, those drugs were developed in parallel, if you will. But in general, if you have patients who have no treatment options whatsoever, then the drug could be approved based on phase 2 trial data. That's where they start. And then, there are still confirmatory phase 3 trials comparing Melflufen to standard of care regimens, to see if it works better than standard of care regimen.
Okay, well, congratulations, because I think that's exciting. Just that fact alone, getting it approved after phase 2. Robert is asking, how is Melflufen on the kidneys? That's a good
Well,
question.
there is actually a trial going specifically to answer that question, to see how well patients tolerate and if it needs to be dose adjusted. So we should have that answer pretty soon. Kidney impairment is so common in multiple myeloma, and unfortunately, for practical reasons, usually clinical trials are limited to patients with fairly good kidney function. We measure that as GFR, or glomerular filtration rate, and that typically has to be more than 30 or 40, where normal is considered 60, and if it's 15, then you're probably on dialysis. So Melflufen was developed for patients with GFR of 40, but there is a study going to see if patients with less functioning kidneys benefit and tolerate it well.
Well, I think for transplant, kidneys aren't really a barrier, right?
No, you're right. It's not absolute contraindication.
Well, Sarah is asking a good question. This is kind of the treatment choices again. So, is there a point you would do a second autologous stem cell transplant versus Melflufen? So, like you have your first and you relapse, and then you have decisions to make. Do you do a salvage transplant? You try the Melflufen instead of that, because I know that they say, you kind of, with each treatment line, you reduce the time in remission, but also transplant, you can expect, I don't know what the official word is, but maybe half or something like that of your response.
So this is a complicated question. I think there's not going to be an easy answer to that, because a lot would need to be taken into account to really give an advice or what would be a better move. We typically try to do salvage transplant if possible in earlier lines of therapy. That's where we have more data. We usually limit it to patients who had fairly long remission after first transplant. And certainly patients have to be fairly fit, and you still have to get them into remission before second transplant. So you have to use something to treat them to get them into that remission, right? While Melflufen you could use if you no longer have things to get them into remission. And you could use it for patients who may not be able to tolerate the second transplant. And melflufen usually doesn't require you to be in a hospital. Well, transplant for the, especially second, typically will be done in a hospital setting. So those are kind of things to take into account.
Those are, yeah, this is a strategy game, right? And we're, yeah, that's why I'm so thrilled that we're doing this with you, because everyone needs to know what their options are so they can talk to their doctor about it, about their personal situation, and sometimes bring it up. Like, have you thought about this for me? Have you thought about that for me? And especially if you're in a community oncology center, they may not be thinking about some of these newer options. So it's really key to be proactive in your care. So I applaud everyone who's watching today, and we'll watch later. We have another question. Do you envision a future trial using Cyborg D versus Melflufen, Vortisimabdex for newly diagnosed patients, to answer that kind of question about bringing it up earlier in treatment lines?
We could see a trial like that, but keep in mind, myeloma field is so rapidly evolving.
I know, isn't it exciting?
It's wonderful.
Yeah.
It's what it makes it difficult to practice, but it's exciting. It's certainly good for patients. I think it's one of the cancers where we've seen most of advance in the last decade or two. So hard to tell if that question will still be relevant by the time we get melflufen into frontline. We may be combining it with entirely different drugs, and we may be deferring it to use in a transplant setting, right? So we'll yet to see.
Okay, I'm going to ask maybe one or two more questions. We all love your glasses, by the way. I mentioned that in the chat. You're absolutely wonderful. Okay, Steve is wondering, do patients with high-grade thrombocytopenia need to alter oral care? So
if your platelets are very low,
that like a little bit more.
Yeah, if your platelets are very low, you have to be careful when brushing teeth. You may either want to use a very soft brush or even a sponge, depending on how your low platelets are.
Okay, so do you have to alter oral care with Melflufen, or be concerned about that at all?
Did I get the question right? Is that what they were asking, because of the low platelets?
Yes.
The oral care. Yeah. So, you would be in touch with your doctor and they would tell you that now your platelets are low and these are things you have to avoid, like no shaving, or maybe brushing only with soft toothbrush or sponge, and no straining, watching your blood pressure, not taking medications that can further thin your blood, like stopping aspirin, no ibuprofen. There are quite few thrombocytopenia precautions, as we call them. I think that actually the hardest one to know is constipation. When patients have low platelets, you do not want them straining in the bathroom. They could bleed on both ends.
Interesting. Okay, so that's good to know about. But good tip. Okay, I think my last question is just about duration of therapy. So when you are on Melflufen, you go once every 4 weeks, like you mentioned, and until progression, really, right? There's no set time frame of administration.
Yeah, so either till progression or intolerable side effects. So all the drugs, they come with parameters. In order for us to dose the drug, the platelets need to be certain level, the white cell count needs to be certain level, liver kidney function needs to be certain level. And if the platelets are too low or white cell count is too low, treatment may have to be deferred. And then we watch patients and see how things change. And sometimes it's the platelets that recover first and we're able to treat again. And sometimes it's the disease that progresses while we are waiting.
Yeah. Well, Dr. Panner, you're spectacular. Thank you so much.
Thank you. Such a pleasure to be here.
Yeah, this is the absolute perfect way to launch this relapse refractory chapter. So I think you gave us a lot of hope and knowledge that we need to move forward. And one more tool in the toolbox, I know for myself that, and for other patients that we help support and educate, being in this relapsed or refractory state causes a lot of stress. And
Mhm.
having new therapies for these patients is comforting to know that you have yet another thing you can go do. So it shows the need also in what you talked about for clinical trial participation, which we always try to promote.
Mhm.
That you should think about trials because sometimes you get access to these, well, all the time, you get access early to these drugs that are helping come to the clinic. So I want to try and just thank you once again and turn the time back over to Audrey for our closing announcements.
Thank you.
And thank you, Dr. Prana. That was amazing. Like, I loved how clearly you explained it because I'm pretty new to the myeloma field too. And so just I learned so much through your presentation. So thank you. I
My
really
pleasure.
appreciate that. And thank you to all of you for spending this Friday evening with us. We really appreciate, we're kind of amazed at the turnout. There's been over 100 people here tonight watching, and we're just so grateful for you spending the time. Like Jenny said, we're going to finish up with just a couple announcements. Um, our next relapse refractory myeloma patients chapter event will be in early May. And we're still working to coordinate schedules, so the date is to be determined, but we are going to be talking about approaching the CAR T, which was mentioned, it was just barely approved. We're going to be talking about approaching it in a practical way. So what is the procedure like? Who qualifies for it? How do you enroll? Things like that. And so we're going to keep you updated when that will occur and who will be speaking. You might be interested in other upcoming events we have in the myeloma crowd community. Tuesday, April 6th at 1 p.m. Eastern is our myeloma financial coach chapter. We're going to be talking about maneuvering the work environment when you have cancer. Join our myeloma financial coach, Diana Valentine, as she explains your options and your rights when returning to the workplace or when deciding to leave the workplace. Wednesday, April 7th at 4 p.m. Eastern is the launch of our immunotherapy treatment chapter. We're going to be talking about vaccinations, especially COVID-19 vaccinations and myeloma. Multiple myeloma specialist Dr. Mike Thompson will be speaking, and he's going to be sharing updates about what we know about the COVID vaccines, how they're affecting the multiple myeloma population, including if it's worth it to get the COVID vaccine pre-stem cell transplant, pre-CAR T, and how long you should wait after those procedures before receiving the vaccination. That same day, Wednesday, April 7th at 7 p.m. Eastern is our Fitness for Myeloma chapter event. And we're going to be discussing the benefits of fitness for myeloma patients with Dr. Jens and Michaela Hillengas. Dr. Jens is a multiple myeloma Dr. Jens Hillengas, is a multiple myeloma specialist, and his wife is a personal trainer. So together they're going to be sharing early data from their study about the benefits of fitness for myeloma patients, as well as sharing practical tips and exercises for staying active at home. The link to sign up for any of these events can be found at the bottom of this slide and will also be sent out in our follow-up email. Another thank you to our sponsors, without whom this wouldn't be possible: Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, who provided the slides today, and we're grateful for that, and Takeda Oncology. And another thank you to everybody involved in this for helping us grow our myeloma crowd community. We appreciate you, and we hope that you have a wonderful night. Thank you.
Thanks, everybody.